as well.
It was on a button that said more.
Uh,
Usually it comes up as a little red spot, but not it was not visible. Well, we've got a couple of loyal people here. Anybody have anything they want to talk about? I actually participated in a case this week, not personally, but consultatively. So I can comment on something, but if somebody has something that they've been more hands-on, that would be best.
I do have I've got something that I've been holding on to because I've got some questions and what are your thoughts on a case that's had a poor outcome. But I'm also happy to save that for another time as well. It's probably going to be centered
No,
around.
go ahead and start.
All right. Well,
I probably need to give you permission to share, huh?
I think I've got it.
You got it? Oh, good. Summer's really on top of this stuff.
All right. I think we're there. Can you see this?
Yeah, but I got something crazy going on my computer. Hang on a second. Oh boy, it's acting up. Yeah, I see it.
All right. Well, we've had a busy couple of weeks. I am catching up on some sleep finally, but we have had a number of toxicities that we've been treating.
Well, before you start that, I was on a meeting yesterday with Emmanuel. So she was doing a dialysis and hemoperfusion study with the Seraph device on a septic dog. Then they had a TPE come in, and then she had two toxicities that she had to do hemoperfusion on. So that was a day.
She wins. She wins. And Carolyn was also, up for like 36 hours, I think, for that. Mine wasn't quite so bad, but I was at the hospital for 22 hours straight with an emergency shift in
We
between.
give you a badge, a badge of honor for that.
But these have been great cases. We had a nice discussion last rounds on a hemoperfusion case out at MedVet that developed an AKI. So I was gonna share Molly on the left here.
Well, that'll be a good topic because the case I was going to talk about was also a hemoperfusion that developed an AKI. So this could be a good theme.
Well, let me. I just want to also say we stopped treatment on this was Marley. She was our chronic kidney case after 107 days and 33 treatments. They decided to withdraw treatment. So we said goodbye to her this week as well. So it's been a bittersweet couple of weeks here. But the case I really wanted to get a little bit of input on, and I've got a little bit of a big kind of picture overview and then some nitty gritty on this case, Cyrus, because I struggled with him at the end of his time. So he was and was past tense, a 5-year-old male castrated domestic short hair whose mom owner had recently lost a member of her family, and there were a lot of flowers in the house, bereavement flowers and bouquets. And we suspect that it was probably that which caused his severe acute kidney injury. He had no history of any kind of kidney disease prior, but we think there were probably lilies in the home. It seemed to make sense as we ruled out other things and looking at. I don't know what the highest creatinine you've seen in a cat is, but I was pretty darn impressed with this one.
Yeah, my highest creatinine ever it was 40. So you're real close.
You're always
and the BUN was 400.
All right. I got work to do. I got work to do to catch up over time here. But so this was him presentation, and as we went down through his investigation, it certainly didn't seem to fit that he had anything besides the AKI from Lily's ultrasound. His renal pelvis were not like screamingly dilated, like a really terrible pyelonephritis, but obviously it's still on the list. And he was getting treated for it. No gross bacteria. Didn't have any obvious obstructive disease. With numbers like that, those were my two, Lily's versus obstructive disease, were kind of at the top of my preliminary differentials. So as we got down to it, we thought he was probably a Lily cat.
Well, go back, Jethro, if you would.
Yeah.
So everybody's ultrasound machine shows things a little bit differently in terms of the contrast. But it looks to me, like this cat, the cortices are a little bit hyperechoic. And it may be just the way your ultrasound machine does its contrast. But we do see, I think that we see this hyperechoic picture of the renal cortices to some degree with Lily, just like we would with antifreeze. I mean, it's never as intense or as bright as it is with antifreeze, but I think that's a sign that could suggest Lily as well.
Okay. Well,
Or from your experience with your ultrasound machine, do these look normal or do they look a little hyperechoic?
no, they definitely look a little hyperechoic, and we've got some kind of steatitis around them as well. But the kidney, yeah. And interesting, you bring up ethylene glycol. I didn't mention that. He had been spending time in the garage where some of these flowers were. They didn't think they had ethylene glycol in there. He didn't have some of the other, his calcium was normal. He didn't apparently go through any kind of neurologic phase. I didn't think that he was an ethylene glycol, but I guess I couldn't rule that out entirely, given that he had been in a garage area space too.
Well, that wasn't my point. My point was just that Lily
Right.
can present with these hyperechoic uh, appearance to the cortex.
Perfect. Perfect. We placed
Nice catheter.
Mila 8 French 16 centimeter dual lumen in the right jugular, and with projected blood flows, I usually 50 to 75 or so, and that was the right size for him. Although you can see it's a little bit long there, but buried at the neck there for cleanliness.
Well, can you go back to that one for a minute too? I'd like to make a comment on that because
Yeah.
you can see the inlet port is fortunately in the right atrium, where a lot of times these catheters that aren't necessarily dialysis, and this is not a dialysis catheter, is it? It's just a dual lumen catheter, like the arrow catheters. You might, we use a 7.5 or an 8 French arrow catheter, but the port, particularly the input port, is about a centimeter displaced from the other ones, and sometimes you'll get the tip of the catheter in the right atrium, but the inlet port will be way up in the cranial cava, where you, particularly in a small patient or a cat, you don't get very good flow out of that.
Mhm. This
So you really want to that's the port that you really want to get into the right atrium, unless you're going to have to reverse the flow in the catheter.
this is Mila does present this as a hemodialysis catheter
Okay.
for what that's worth.
But they are pretty far separated, those holes, for a small heart.
Right.
So if you just had the tip in the right atrium, then the inlet port may not get there. Yeah.
Would have been like way up here.
Yeah.
This guy was about 5 kilograms. So the extracorporeal circuit, always a consideration. I don't have a carpe diem, so in an ideal world, I'm putting in a grant to the Feline Health Center. But we can work with what we've got, and so we do have the Prismax, and that's what the platform we use to go with for him.
And I hate to keep interrupting you, but
please.
there's another machine that's going to be coming to, and I'll show you a picture of it here. It's made by Medica. So Medica, maybe everybody recognizes or remembers the Medica VetSmart machine, which was really a piece of junk. But they have another machine that is going to be coming to the US market soon that has a circuit size that's just about as small as the Carpe Diem, but it will do all the modalities. It'll do plasma exchange, it'll do dialysis, it'll do CRT and hemoperfusion. And that might be a machine that people hold out for because it will be dramatically less costly than the Carpe Diem. The bloodlines are going to be, I think they're going to be, the really tiny bloodlines are going to be, here we go. So this is I think this is the company. No. Yeah. They make a whole range of machines, but I've seen this machine. They actually had, this was a human meeting that I saw it at. And they come with their whole line of machines, and they had this one, and I wouldn't recommend the VetSmart machine to anybody. I just never have liked that machine, but they make this other machine that is, I think, and I keep telling them, I think this is a great machine for the veterinary market. So you may see that in a very short time. I think they just got approval to come to the United States, and that might be an alternative to the carpe diem. That would be a smaller circuit and still do all the modalities that you would do on a Prismax or Prismaflex machine or on your IHD platform.
Well, and I think, price point last time I got a quote on a Carpe Diem was right around 100, 110, I think, thousand.
Yeah.
So if the Medicas come in less than that.
I don't know what the price point on this one is, but it's probably less than 30.
Okay. Well, that's attractive. But for us at this point, some of our colleagues around the area have carpe diems, and we don't. But 5 kid cat, we're able to work with that, and so we did set them up on our Prismax. And the smallest circuit I've got is the HF20, which has 60 mils in the circuit, and we added our crit line for a total circuit extracorporeal volume of 63 mils, which for this guy, and he was actually 6 kgs. Ended up being 17.5% of his blood volume in the extracorporeal circuit. His starting hematocrit for us was 38%, and he was cardiovascularly stable, although obviously pretty sick with that degree of azotemia and hyperkalemia. He had been treated overnight, or for some period of the day before I got involved, with some volume and all the typical treatments to hide the potassium until flow can be reestablished or it can be removed with an extracorporeal therapy. So I don't know if I know we've only got a couple folks on here. This was going to be an interactive place, but to kind of move things along and give other folks time, we chose to prime with a balanced electrolyte solution, just a crystalloid. We are unable right now to get any of the synthetic colloids. All of ours expired, and the ability to get some has been impaired. So I don't know if that's something that other folks are experiencing as well.
Well, I heard that a couple of months ago and announced it on IRRR one time, but that's a shame.
Because that would have likely have been my choice had I had access to it. I'd probably have cut it down to a 6% head of starch or vet starch, so kind of half and half with a balanced electrolyte solution, kind of based on Catholic study.
You could have used a little plasma too if you had that.
Yeah. So we went with, he was again in the state that he was, and he wasn't anemic, so we went with a balanced electrolyte solution for him. And this was just meant to show, trying to keep this guy warm, and we actually did. It was pretty impressive. I couldn't believe we had decent body temperatures for him, but he was under a whole lot of blankets. He had the bear hugger going. We had a warm water pad underneath him. And then I've got this external heating pads that I put over the circuit lines as well, going to and from the cat. And I know I've got on my shopping list to get one of those Suve things that I know you guys have talked about before.
Yeah, I'm looking. You can get them on Amazon for $80.
Yeah,
I'm
not bad.
looking for a picture of that. Go ahead and I'll see if I can find a picture of that while you're.
Yeah. So that's on my list. Although this for this cat, this did a pretty reasonable job for him. From the prescription, we looked at him, and based on where his starting BUN was, it was over 300. And so we were aiming for at least, based on the IHD guidelines, 35%, but at less than 5% URR per hour. And so, given the time of day and the staffing that we had, we chose a URR target of 50%, 5% per hour. So that gave us a treatment time of 10 hours. Using the chart and using the updated version, the current way to prescribe some of these kidney replacement therapies, that URR target of 50% equated to a KT over V of 0.7. Our patient's total clearance, given those parameters, would be 2,500 mils, and at 10 hours time frame, that's 250 mils an hour of clearance. So again, another opportunity, on a different stage. This presentation's for a bigger audience, but diffusive versus convective clearance plan is, we've got the option on the Prismax to choose a combination thereof. And this is where, again, for a newer audience, I get into some of the differences between diffusive and convective clearances and some of the nomenclature and discontinuous versus continuous in the spectrum there. I'm going to sit right in the middle here in that PIRT, right at the intersection of those four different quadrants. And I like to do a little bit of a combination if it's feasible and practical. So we did choose to do not CVVH HDF, but to do a prolonged intermittent treatment using both hemodiafiltration. His potassium coming in, the other elements of the prescription here, looking at potassium, the general rule of thumb, patients plus dialysate or replacement being 7. He had 8.8, and so my initial treatment fluid for the dialysate was going to have a potassium of 0 for a little bit of time, and I was going to, and I did ramp up from there. So we had a dynamic prescription of replacement slash dialysate fluids during the treatment based on the potassium there, and we followed it with venous blood gas monitoring. But initially, I chose to start with a purely diffusive treatment, the 250 mils an hour of treatment that we calculated a little bit ago here using a dialysate with a 0 potassium. We were able to achieve a blood flow of 50 mils a minute, and that gave us a blood flow to dialysate flow of 12. So we knew that we were fully saturating our dialysate. Happy with that. About 2 hours into the initial treatments, we rechecked a potassium and it was down to 4.52. And so at that point, we modified.
You were using the HF20?
Yes, sir. Yep.
Yeah.
So at that point, I modified our plan a little bit and I split the treatment into a combination of diffusive and convective clearance treatment. And so I split just the 250 mils an hour into 120 mils an hour of dialysate, diffusive clearance. From a practical standpoint, I kept going with that bag of 0K, but my replacement fluids, running at 130 mils an hour of clearance, I used a potassium of 4 in that bag to achieve some balance there, so I wasn't dropping his potassium too rapidly or too much. Remembering we want to keep our filtration fraction below 20% or so. For folks that aren't recalling filtration fraction, it's the flow of total ultrafiltration divided by plasma flow, which in this case, we were doing replacement. We did not have any pre-blood pump flow, and we were not doing any net ultrafiltration. So essentially, it came down to the replacement flow over the plasma flow. Which is, again, recalling that plasma is the blood flow times the inverse of the hematocrit. And that got us a filtration fraction of 7% using that clearance of 130 mils an hour of convective clearance. So we were happy with that as well. And he trucked along. This is one of those practical pictures. We don't usually eat and drink in our dialysis room, but I did have, because this was an unplanned treatment in the middle of the day and I had some childcare responsibilities, I brought my son with. So he had to be entertained and we had to keep him fed in the corner there as well. I could keep an eye on him. So he was hanging out, cap and mask, but still had his treats over in the corner. And he did really well for that until he got picked up by his mom. Our treatments did last 10 hours, and using the math and the prescription, and I did utilize Cedric's dialysis calculator that he has graciously shared. We were pretty well on target for that 5% URR per hour. You can see our nice gradual decline there over the course of that 10 hours. And our endpoints, we had a URR of 46%. Creatinine dropped by a little bit further at 55%. And he ended up with a normal potassium at 4 by the end of treatment. And this was him. He was a lot brighter. He was interactive even a little bit. Seemed to be feeling a fair bit better than when we started this, but still pretty sick guy. And so
That's a nice treatment. That's a nice curve.
yeah, I was happy with it. It did nice for us. I could have gotten some more time points, data points in there as well. But
And this is one of the beauties of doing these slow PIRT treatments. And again, you need time with an animal with a BUN this high. You've gotta be very gentle with them, and it takes 10 hours to do that, to get enough change where it's significant. If you'd chosen a a 30 or 35% URR, the next morning you'd be right back where you started the first day, and you'd make very little progress. So that's really beautiful.
And speaking of the next day, and this is where I'm going to start, talking about my hubris a little bit. Maybe I was so excited that we were just under 200, because that gave us, again, maybe a little bit of flexibility to be a titch more aggressive the following day. And this is where, I'm looking back with, well, I'll be looking for input on some of how the second treatment went here. So we did get to the next day. We ended up, oh gosh, I think we wrapped up around 2 a.m. That night, and got him to bed in the ICU. And the following day, these are the numbers from 10 a.m. So just about 8 hours later. And we got him back on the circuit and did a second treatment shortly after 10, 11 a.m. or so.
So he
Because
bounced up. So his rebound was 50 points then, from 150 up to almost 200. Yeah.
Yeah, 165 up to 197. So, 32 points.
That's a big change in that time period.
So, I looked at it, and again, we'll get to the end of the story here in a minute as well, but perhaps I should have, looked at this range here, 200 to 300, instead of, where he was just under the 200. And I said, okay, well, 10 to 12%. But thinking now he's a small creature, and cats and DDS, which I'll talk about here in a minute, is certainly a much higher risk, and that degree of azotemia as well.
Jeff,
Yeah.
let me just, so is this the current recommendation from the hemodialysis guidelines? I always thought that 200 to 300 was 5 to 7.5 URR per hour. Does it up to 10 now?
I am pretty sure this is the updated version.
The older version we had was 5 to 7.5.
Yeah, I've been updating. I've had to update all my charts based on the new guidelines, and I'm pretty sure this is the updated one.
Or maybe it was greater. It might have been greater than 300 was 5 to 7.5, but where you were, I think I would have gone with the 5 as well.
Yeah. So we got to our second treatment, and maybe again, my hubris a little bit aggressive here. KT over V of 1.8, 7150 mils of total clearance. And we did a similar combination of diffusion and convection, and we've already done the math, so I'm not going to fly through all of this. But here was his curve, and we were on track for the targets, over that 7 hours and 10 to 12% per hour. A little bit aggressive though, looking back on it. One of the other things with him, his crit dropped a little bit. He's 38% before the first treatment, 25 at the start of the second treatment. Still cardiovascularly stable. We did not give him any blood products before or during, or as part of his prime. But certainly by the end of treatment, he was telling me he was going to need more, definitely before his next treatments, and we were watching him for indication that he would need a packed red cell transfusion overnight. So, here's our curve for him. Again, as you average it out, it did okay, but this was a little bit steep here at the start, I think, given where he had come from the day before.
So is there a change in the treatment at that break point at 3 hours where the curve seems to change, or is it just that you don't have enough points to?
It's just I don't have enough points.
Okay.
Yeah, we didn't change anything at that point. We were, no. So I put him to bed in the ICU after the 7 hour. It was a little bit longer than 7 hours, and this is him actually, and Patricia is holding him. Again, stable, bright, looking good for himself. And we put him to bed in the ICU, and he did okay for about an hour or so. And I've just got some serial blood work on him here. This was before treatment, kind of mid-treatment, and at the end of treatment here. And unfortunately, a couple hours after finishing, he became less interactive. took a few agonal breaths, showed signs of anisocoria, and he rested at that point. And he was a do not resuscitate, and so no interventions were made at that point. He was progressively anemic at that point. So, he came off our treatment with an ACT, a final ACT. Oh gosh, I don't have it written down here, but he was still a little bit, he was just under 200 as our final ACT, despite we had turned off the heparin a good hour and a half before the end of treatment, based on where he was, or sorry, a good hour before. His lactate was profoundly elevated from before. He was euglycemic. We didn't see any major shifts in his sodium over that time, but he was certainly more acidemic and metabolic acidosis. So this was peri-arrest or just as he was arresting here. So a couple of thoughts for him that I had. Certainly,
So he came off the treatment with a bicarb of 16 or 17.
he came off the treatment here at this was before
Oh, this,
treatment.
okay, yeah,
This
that
was
was
halfway through, and this
okay,
was the end. And
yeah,
this was him at arrest. So, you touch on the bicarb, and I've got a few slides on the development of dialysis disequilibrium syndrome. I certainly did look at this bicarb, and it's one of the things I'm a little bit challenged with the prepackaged replacement in dialysate fluids, because you're stuck with the bicarb that they give you. So there, certainly a rapid correction of his bicarb in that time. Certainly the URR, over that time, which I've touched on already, and how quickly or maybe that came down a little bit too fast. And we've got the anemia. So we've got kind of three different potential mechanisms that could have led to his arrest.
yeah,
In addition to having bled somewhere from his heparin from treatment. Oops. So those were kind of in the back of my mind as I looked at this. And just for reflection and remembering about DDS, one of the reasons we adhere to the guidelines is because of the risk, especially on these smaller patients and in cats and the severely azotemic patients. More likely in the first couple of handful of treatments. And there are a couple of different suggested etiologies for the pathogenesis. But there is still some work to be done on nailing it down completely, I think. But clinical signs include agitation, disorientation, seizures, vomiting, coma death, somewhat acutely in these cats. And the risk is certainly during the treatment and anytime 24 to 48 hours after dialysis. So all of my kidney replacement therapy dialysis patients are on seizure watch with mannitol orders post-treatment. In the transition for me to doing more of the PIRT with and continuous platform like the Prismax versus when I would do the bypass or slow dialysate treatments on an intermittent platform. I've been less likely, unless it's indicated, to give preemptive treatments with mannitol than I used to in the old days of when I started with this. But this is, kind of triggered me to think about in a patient like Cyrus, maybe there's some indication for that.
yeah,
The reverse urea effect, we know urea's got a wide volume of distribution. In health, it's an ineffective osmol. We clean it readily with our clearance treatments. But the redistribution from the intracellular space is slower than we remove it, even with a very carefully prescribed treatment. Our removal from the intravascular spaces can exceed the redistribution from the intracellular space. And so some nice graphics on the theory of the reverse urea effect. Aquaporin channels are upregulated, or thought to be upregulated in severe uremia and azotemia, meaning water can shift both ways more readily. And urea transporters are downregulated, as you can see in this B chart here. So we've got fewer of the urea transporters, more of the aquaporin channels. And so if we clear the intravascular space of urea, it leaves behind what in health is usually an ineffective osmol, becomes effective. And with a combination of downregulated urea transporters and increased aquaporin channels, the movement of water in the reverse direction or into the cells, particularly the cerebral cells, leads to cerebral edema, seizures, comas, agitation, death. Just another colorful version of the same thing. I like both of these versions of it, but this just shows kind of the same thing, the aquaporin channels and the downregulation of the urea transporters in this condition. They have looked at a number of rat studies, and there were some other thought around idiogenic osmoles being another component to the development of DDS. And they, have had a hard time identifying in rat brains with severe uremia the presence of those idiogenic osmoles, but there's still some thought that that could be part of what's going on too. And then this is the other, part of things too. This rapid correction of acidosis can lead to a paradoxical CNS acidosis with bicarb rapidly diffusing from the dialysates or replacement into the bloodstream. It buffers hydrogen nicely. And we saw in my blood gases there that the bicarb improved and corrected, as we might have anticipated or expected. But as that bicarb diffuses into the across the blood-brain barrier, or goes through to water and CO2, CO2 diffuses across the blood-brain barrier and is converted back. But those polar molecules are trapped in the CNS, and that's where we can contribute to paradoxical CNS acidosis. So for Cyrus, I think there he is as a kitten on the left there. For Cyrus, I think I could point to a number of those things. I think, I probably should have given him the benefit of the higher starting BUN and adhere to a more conservative guideline for removal for my URR removal rates and KT over V. And I think, potentially, I think that's probably the most likely contributor to his passing. And I think it was DDS. I think the rapid correction and, changes with his bicarb and whether there was some paradoxical CNS acidosis, certainly the drop in his hematocrit could have led to his demise as well. And maybe he was bleeding and that was, 14 was, certainly well within the range where we should have rapidly transfused him some packed red blood cells at that point when we recognized it. He arrested a short time later before blood was being gathered from the fridge to give to him, but he arrested before we could give it. So those were my thoughts on Cyrus, but I'd love some feedback and some other thoughts from you and the group, and see where I would go differently next time.
Yeah, well, that's unfortunate. Although you may not have saved these kidneys anyway. I'd make the following comment. I think we changed to go to the bicarbonate issue. I mean, we change bicarbonate in dialysis patients within that range all the time in a much shorter period of time. And so that disequilibrium we see there, that paradoxical cerebral acidosis, particularly in dogs, we primarily recognize that during the treatment. They just start panting because the brain thinks that it's acidotic. So it's going to blow off CO2, and they just start panting. That's why we've started, you could set your, on an IHD platform, you could set your bicarbonate at 40. On some machines, you'll even go up to 45. But we found over the years that in a dog in particular, if you get to about 32, then about 3 or 4 hours into the treatment, they're just and it's pervasive. They just can't stop panting. And so we usually don't go above 32 with a bicarb just for that reason. And I don't think that we've ever experienced what would be disequilibrium from the bicarb. But you get bicarb up 35. And what was the bicarb in your dialysate?
I'm just bringing that up now. You know what? It's 32.
Is it?
Yeah.
And I don't know that I've made that same observation. I don't recall making that same observation in cats particularly, but in a dog, I mean, it's just really, you get above 32, and about 2 or 3 hours into the treatment, the animals will just start panting. You'll think they're hot and you cool them off, but it's It's probably the paradoxical cerebral acidosis. And so if we stay below that, we generally don't see that very much. And again, we make changes in bicarb within that range, Jethro, all the time, and I don't think we see disequilibrium signs from that. To me, what typically happens with disequilibrium, and I think it wasn't aggressive. I probably might have done the same treatment. You know, I'm kind of an aggressive sort of dialysis person, but every once in a while you get tagged. And I remember the last time I got a little aggressive in a little black cat, and it's typically a cat because they're more predisposed to it. And that cat, yeah, that cat died as well. And it's the same thing. It's very sudden. It's very acute onset. Their eyes dilate and then they just drop. So I think, to me, that, and not to spank you or anything, but I think that's the most likely. But I don't think you can discount the anemia as well. I mean, you could have those same signs with from the hypoxia and anemia, I would think. But if I were to label this, and we usually try to put a name on our complications. If I had treated that cat, I would have said that this was disequilibrium.
Yeah, I
I
think
was just going to ask, sorry, I was just going to ask what do you think was the cause for the anemia?
Um, I suspect he must have, he was still moderately heparinized, despite me turning off the heparin earlier than I usually do, just because he was riding a little bit higher than I wanted. So I wonder if he had a little bit of I wasn't there in the hospital at the time he arrested. So I wasn't there to do a point of care ultrasound to see if he had some internal hemorrhage. That was my best thought, that he went from 20 to 14 from some hemorrhage internally somewhere that I didn't identify.
And it could have been the anemia as well. I mean, anemia
Yeah.
would look just like that. I'm not the anemia, but that anemia, that low pack cell certainly would have looked the same way, I think.
Yeah. And
It
lactate.
may have been a little slower in development than dialysis disequilibrium. I mean, it happens in a couple of minutes typically. These cats are fine, and then they just boom, they drop.
Yeah, I think I think they're not mutually exclusive either. There could have been some combination of the two, but
Yeah,
I think
sure.
you're right. I mean, either of them I can point to as saying, hey, could be a reason.
But nice curves anyway.
Yeah,
So that second UR was at 85 or something like that you were
it
targeting?
was here. I'll bring it back up again.
I just looked through about 400 images and I haven't found the SUVE yet.
There it is here. So 82%.
That's a little aggressive for a second treatment in a cat this high, I think.
Yeah. Yeah, and this was first treatment. Yeah, I think
Did you have a crit line on the cat during the treatment?
we did, yeah.
And was there any evidence of bleeding from that?
Let me pull up his. I think I would definitely err on the side next time of him, being higher. Even though he was just under the 200, I would
I might
definitely
have done
next time
another
kind of
50%, another 50% treatment.
yeah, I would.
Maybe with a little bit shorter time period, maybe 50% in 7 hours or something like that. But that's
Yeah, no, his crits so 24, 22.7. He started about 24, 25, and no significant drop during the treatments.
during the treatment, yeah.
When I
And again, you can have that disequilibrium occur post-treatment. It most commonly occurs during the treatment, but I've had some patients that, and I haven't seen a lot of disequilibrium because once we recognized it, we got really conservative. And we haven't had I think I caused the last one. And that was years ago, maybe even 8 or 9 years ago. But that's when you get religion. So that experience that you've had will give you religion that will make you a more conservative on these kind of cats in the future.
Yeah, that for sure, for sure. And this was his course during treatments. I probably could have addressed some of that there as well. But in any case,
Well,
um,
that's a interesting, and so that wouldn't have been dilution, I don't think, right? You weren't doing anything to hemodilute him.
no, no, he was not.
So he may have been bleeding during the treatment a little bit too.
He was getting a little. He was getting some external crystalloids as well.
Okay.
And when I look at looking down through his O2 sats from the crit line, he was riding a little bit low on the O2 sats as well. And so we had some external crystalloid volume going into him also. So some of that could have been a little bit dilutional too.
I'll tell you, so we're just finishing up the hemoperfusion guidelines. And one of the guidelines that we suggested in terms of monitoring was that if you had a crit line monitor, that even during hemoperfusion, you probably ought to put that on there. And the way the guidelines work, the committee makes the guidelines, and then they send it out to an independent blinded review panel to make comments and approve the guidelines. And you have to have this jury, and we actually had a jury of 15 people, not 12 people. And 75% of the jury has to agree with the guidelines in order for it to pass. And some of the comments came back, well, for hemoperfusion treatment, it's just one treatment, and and there's for no reason to put the crit line monitor on there. But you can put it on for other reasons. Some of those animals are really critical, and the crit line monitor gives you valuable information on the hemodynamic status of the patient, the whether your anticoagulation is causing any bleeding. If it's an NSAID, you might have a gastric ulcer or something. The animal's going to bleed from that, and it just gives you a lot of useful information. And I put it on every treatment I do, even on my plasma exchange. And there's no method to put it on the machine for the centrifugal plasma exchange. I actually have to cut the blood line and insert the column in the cartridge in the blood line to do it, because it gives me information that otherwise you never get, and really makes you understand. So on all of these treatments, I just really recommend that you do that. And here you see in this example, now we can see, well, there was a trend in the hematocrit over time. And I don't know how much longer those machines are going to be available, but boy, I just use it on every treatment.
Yeah, I agree. I put them on my hemoperfusion. I mean, they go on everybody. They go on everybody for sure. And that's, I've enjoyed and appreciated, we've been running the Blue Star, the IHC platform for the last couple of months. And having it integrated into that platform is a really nice piece of technology there.
Yeah.
And then I've got my separate one. Actually, in the horse that we did, I was actually I put in the crit line 3 chamber as well. I've got a little stash of those. And I've got an old crit line 3. And so running at 350 mils a minute on that horse, we were able to get some access recirculation data from that, which actually remarkably showed like 4 to 8% access recirculation running at 350 mils a minute in that horse. So that was
And what catheter?
cool info. It was a 14 French 30 centimeter Medcomp.
The traditional one we use.
Yeah, yeah.
Well, in a horse vein, with the flow that would be there, you might not expect too much recirculation.
I know. Well, Carolyn up at Tufts had said they did a mini pony, and they were getting a ton of access recirculation, running too fast blood flows. So I was like, okay, we got to know for sure. The only catch with that, and I won't bring up the pictures again. So I also incorporate into the hemoperfusion and all the treatments as well. I had a little technical issue with one of my recent ones where it attaches to, I was using a carbon column, where it attaches in there in the threads was not quite lined up quite right. And then the weight of the monitor kind of bent the crit line chamber down and actually introduced a little bit of an air leak into the circuit right there, which was, more on me and my technical, I should have really cranked on it and not had a little bit of weight on there. But
Yeah, you have to crank, even on a dialyzer, you have to really crank that thing because it doesn't thread. I mean, it's a softer plastic,
Mhm.
and it doesn't thread like like the normal hard plastic connectors do. And you really have to crank on it and crank on it and crank on it to make sure that it gets all the way down.
Yeah.
And it could be loose. You're right. It could be loose if you don't get it cranked the whole way. So so Tony or Andres,
I do
any
have one quick question.
no,
It's-
no, we got time for a quick one or a short one or a long one.
well, I don't know if this is going to be a quick one, but I'm trying to do more prolonged treatments. I'm starting to do the treatments in the Prismaflex for more than 24 hours. So I was wondering if any one of you have any advice or something. The most I managed to do the last time was maybe 35 hours, something like that. And the treatment went pretty well, but I do run with some problems with bleeding with these patients.
And you're using heparin or using
Heparin,
right?
no heparin.
Well, and how are you monitoring the heparin?
Only with the right now, I only have a PT and PTTA monitor
Oh,
because
okay. Well,
I
that's
haven't got my hands on a ACT plus that
well,
they're
PTT is good. Usually it's more expensive and we don't have as much experience with it, but and what percentage increase in the PT are you providing?
I'm aiming at least a 50 or 100% increase in the PT, but it's a little bit tricky with this machine because sometimes it give you a correct number and sometimes it don't. So
Oh, well, the ACT will do that too.
okay.
Well, I can't talk with any experience there. The longest one I've ever done was 24 hours. Um, so Dr. Segev he doesn't run them very often more than 24 hours, and they usually switch over to intermittent. But I think they have maybe some that they've run for 2 days. Were you the only were you running it all by yourself for those 35 hours, or
With my technicians.
you'll be as sleepy as Jethro here?
Yeah, it's long hours, but no, we switch places with my technicians, and
Okay.
but I'm trying to do this because I want to get the most out of the set, right? So I'm aiming for supposedly the most you can use it is 72 hours. So I'm
Yeah.
actually aiming to do that. So I was wondering if anyone have any I don't know piece of advice. I was just reading the slides of Segev because he gave a class of that. I missed it, but I'm trying to catch up with that information also.
Yeah. So, I mean, I know that they don't traditionally run more than about 24 hours, and they've developed this system in their ICU where they do the initial assessments and set the patient up, and then their ICU techs run the treatment while they're sleeping. The other
Hmm.
person who may have more than 24 hours worth of experience is Dr. Acerno. He was kind of the CRT guru for for a long time. The Tufts group was doing a little bit, but when he was at Purdue, he was doing traditional conventional CRT. Um, I don't know if he went out 72 hours, but I don't think he had an intermittent machine. So, but he would be another one that you could reach out to and see if you can't find his email address, I could get it to you. But he's the other one that may have some experience with really long-term CRT treatments.
Great. Thank you.
Is he
Yeah.
in Florida now? Is he at UF?
No, he's with Northwestern University, and he was in Phoenix, and I think now he's in Minneapolis.
Hmm.
I'm actually, I will see him on a meeting at 11 o'clock to be if he comes to that meeting. So we're scheduled to have a meeting at 11 o'clock, which he's going to be there, and I'll ask him what his long-term experience is with that, and if he's gone more than 24, 48 hours, I'll have him get in touch with you.
Thank you. Thank you.
Let me just quickly talk about a case that San Diego had. So this was a 17-kilo young dog, I think about a 2-year-old dog. I don't remember the breed. They got into naproxen, and they thought about 30 pills, something like that. And I haven't had an update today. The most recent update I had was yesterday. And so this dog presented about, I think he was exposed about 10 o'clock in the morning, and got to the emergency service of the group that program affiliates with in the late afternoon. Maybe it was 3 or 4 o'clock in the afternoon. And I don't remember whether he went through a couple of primary veterinary centers before he got to the specialty center. And arrived bright, alert, responsive, looked perfectly clinically normal. He did vomit it up a bunch of pills. I think he vomited up, they counted 20 pills. And they thought that he got exposed to about 30 or so 500 milligram naproxen tablets. So they estimated that maybe his toxic burden was about 5 grams. And they were going to do hemoperfusion, and that size dog, Andre, who was doing the treatment, didn't have a 300 mil carbon column to do it, and so he called me to see, how but they did have a couple of 100 cc Dublin columns that he could have used, and so we decided that, and at the time, I wasn't entirely sure what the capacity was. And so I can give you that information now. We've had a lot of discussions with Jeff, and we've had a lot of talk about this. And it turns out that the current recommendation is the 100 mil carbon columns probably have the capacity for 10 grams of drug. So for that one of these columns would have perfectly covered that dog if his burden was 5 grams. For something like ivermectin or some other toxin that's within micrograms or nanograms of exposure, I mean, you'd have tons and tons and tons of capacity, even with the small column. The bigger column they're suggesting has the capacity for 15 grams of NSAIDs. So you can use that if you kind of have an idea of what the toxic burden is to the animal. You can figure out what size device you need. We had a dog years ago that we treated before we had some of this information, and it was a great big, about a 25 or 30 kilo Rottweiler, and at the time I was on the phone with Jeff, and we weren't entirely sure what the capacity of the 100 mil columns were because that's all I had on hand at the time. And we actually exchanged. We thought that about 3 to 5 blood volumes and the device would be saturated. I've got data on that, and in fact, the column at 5 blood volumes, the column was, and this was for ibuprofen for that dog, the column was still absorbing really, really well. So, but we exchanged out 3 of those, and so I'd recommended, why don't you do 5 blood volumes on the one column, and then change out and do another 5 blood volumes on the second one, and that wasn't probably the best advice. We should have done more blood volumes on this dog. Because now we know that the single 100 mil column would have managed the whole capacity of that patient. But he came in, the dog came in clinically normal, almost essentially no clinical signs at all. The creatinine, I think, was 1.2. The SDMA was 14 or 15. There was some funny numbers with the cystatin B. So there were 2 samples of cystatin B taken at the same time. One was submitted by the specialty hospital, and one was submitted by our program in San Diego. And one of them, the cystatin B was 50, and the other one, the cystatin B was 150. On the same samples taken from the dog practically at the same time. And so that was data, you know, because cystatin B would, at that time period, could have told us whether the animal had active kidney injury going on at that point. And so you have to flip a coin. You know, one of them kind of tells you, yeah, that looks like there's some active injury going on, and one of them tells you there's nothing. So that was probably a laboratory error. He did get blood samples throughout the treatment, so we've got those data, and we can find out what the toxicity change was over the treatment. But 10 blood volumes with both of those columns probably cleared the dog, I would suspect. But the next day, his creatinine had gone from 1.2 to 2.3. And so one of the messages is, because we've gone through, for these NSAIDs, we've gone through a couple of cycles, one where we were treating every animal that was exposed, and then we would see animals that we were treating with plasma exchange, probably at that time, plasma exchange, or with maybe hemoperfusion, that came in clinically normal, and you know, but you just treated them because if you didn't treat them, you've lost an opportunity to treat them. And then we saw a lot of those animals then we started seeing some animals that, you know, that we didn't treat, and they were doing fine with just medical therapy, and we sort of backed off, and that an animal really had to have more profound signs, usually some evidence of neurologic involvement, before we went in and did hemoperfusion on them. And then people were starting to see these patients that come in absolutely clinically normal after a period of time where they should have had some signs, and didn't treat them, and then they got azotemic the next day. And so now we're back in the camp where, you know, if they're exposed and the exposure seems big, and our guidelines suggest that if the exposure seems big, you're probably better off treating them. And some of the animals you're going to treat, and they probably didn't need it, but at least you've provided the insurance that you've done what could have prevented those animals from having a life-threatening disease with any of the target organ injury that an NSAID could provide. And then the next day, this dog presented with a creatinine of 3.2. So he's got a progressive AKI that if we said, God, this dog's clinically normal, and didn't perfuse him, then he might have had a much more profound AKI going on. Then the other thing that developed was that he developed a pretty acute anemia, and just started feeling really crummy. So here was a dog that was clinically normal, and then by the 3rd day, he's looking really wretched, and on the 3rd day, he's also vomiting up pieces of the pill bottle. So he chewed up the whole pill bottle, and now you don't know whether he's got a GI ulcer, he's got a GI perforation because of the foreign bodies, or you know, is he getting toxic now because of the ulcer or penetration from the foreign bodies? And so that's all I can tell you at the moment, because I haven't had any updates on the dog today. But you can, these stupid dogs that eat these, particularly naproxen. I mean, naproxen's a bad one that's got a really, really long half-life. And so if you don't treat that one, you know, these animals could be really exposed to that drug for a long period of time.
And naproxen's got a much tighter safety,
much tighter
range
safety
as well.
margin as well. Yeah.
That was
So
one of ours.
he probably in the hours that that it took to get him to the hospital, he probably had already whacked his kidneys pretty badly, I suspect. Usually by that period of time, you know, if we see an antifreeze dog, they usually have some bump in their creatinine in about 4 or 5 hours from exposure, but maybe it's a little longer with naproxen. But by 8 or 9 hours, you should see some change, I would imagine. But maybe his creatinine was, you know, 0.8 before, and then it went up to 1.2, which would still be in the reference range.
That mirrors one of our cases that I touched on at the start there too. She came in already vomiting. She was an ibuprofen dog with a creatinine of 1.7. I didn't have an SDMA for her or a cystatin B. Treated. It was pretty. I mean, it was almost 600 mg per kg of ibuprofen, and then, you know, the next day creatinine was 2.1, and then the next day 3.5. Unfortunately, it came down to 2.9, and
Well,
she's
the
coming
good
back
news
the
is
next
they
day.
generally recover from that ibuprofen AKI. Naproxen might be a little harder, but it might take, you know, it might take a week or two before they come back to normal. So that's an extended period of hospitalization and management that you have when they develop the AKI. And then if they get a perf or an ulcer on top of it, then it's a whole different story.
I know we're at the end of time, and maybe I'll revisit when Jeff is on as well. I had some different numbers from the last time we had talked to Jeff about capacity, and
Yeah, he's changed the numbers. It used to be well, let's see. It's
it was
it
15.
used to be 10 and 20. And that was for those were data that were based on Atlas. And Dublin has a little bit less bulk density than Atlas. And so now with Dublin, they've got the numbers have come down about 30% because the bulk density of Dublin is less than the bulk density of Atlas, which is where they got their original numbers from.
I'll have to, yeah.
So
So
what numbers did you have?
I've got from the last time we had this, and I forget the setting, but this was Dublin ibuprofen on the benchtop anyway, without competing molecules. They had 0.6 grams of absorptive capacity per gram of carbon, which anyway,
Yeah.
big picture, 15 grams for the small V100 and 45 grams for the V300.
Oh, that's right. So this changed as recently as yesterday.
Really?
So it's 10 and 30. Instead of 15 and 45, it's 10 and 30.
10 and 30. All right. Well, yeah, that's so he said 45 on benchtop, but estimate 30.
That's based on Atlas.
Okay.
Those numbers are based on Atlas.
Got it. I've kind of I took, you know, some of the other messaging you gave, you know, based on there being other competing molecules in a live.
Yeah, and that's another factor. But if there's none of that, you know, like the in vitro capacity with Dublin is 10 and 30.
10 and 30. Okay. Yeah, that's about I've been doing 12 and 30, so I'll drop it down a little bit to 10. And was that, I mean, that's not specific to, I know they've looked at specific toxins, but that's anything. The capacity is about the
He
same.
says that certainly will cover the NSAIDs.
Okay.
And well, that's the capacity, yes, just about for anything.
Anything, I guess, right?
Yeah.
Yeah. It's based on the carbon binding. So that's cool.
Yeah.
All right, good stuff.
Well, thanks, Jethro, for your contributions today, as always, and Andres for your comments, as always. And we'll call this one to a close then.
All right. Thanks for the time and for the feedback and the learning opportunity. Well,
yeah, well, I've been in your shoes, so don't feel bad. I mean, feel bad, but
it's the path. It's
the
learn
path from it, I guess, is the
yeah.
The message.
Which again, I that's why I want to make sure we talk about stuff that doesn't always go wonderfully in these sessions too, because that's where the learning happens.
That's
right?
what they were designed for, you know, for complications and new protocols and that sort of stuff, just to share our experiences.
Yeah.
And there's no judgment. There's no judgment.
It's a safe space. All right. I'll see you next time.
Okay, take care.
Bye.
Thank you both.
Uh-huh.
Bye.
Bye.